Preventing Cardiac Arrhythmia, a Dietary Intervention by Lindsay Porter. Currently, more than 4 million Americans, mostly over the age of 60, experience some type of heart arrhythmia. And of that 4 million, about 2.2 million suffer from the most common type, which is atrial fibrillation. And these symptoms can be mild to life-threatening. It's been found in current research that magnesium is closely linked to heart health. And we know magnesium is an essential mineral, and the American diet is largely depleted in this mineral, mostly due to low nutrient levels in the soil. Also, processing of food depletes a lot of the magnesium content in our foods. And so for this reason, most Americans consume far less than the RDA of 310 to 420 milligrams per day. It's very difficult to accurately detect deficiency. This is part of the problem with deficiency, the prevalence of it. Blood serum levels are not the most accurate way in testing, and that's the gold standard currently, and that only represents 1% of magnesium stores. And another problem is that magnesium levels are not routinely tested. Usually only when people are hospitalized do they go and look at these levels, or if they have other nutrient deficiencies, sometimes they'll also test for this, but it's not common. Also, early symptoms are really mild, so it's easy to ignore those, and a lot of times the deficiency goes completely undiagnosed. So there is a compelling need now for an objective assessment of total body magnesium stores, some kind of tool that can help measure these levels. We know that magnesium is in various sources of food. It's in nuts, seeds, whole grains, green leafy vegetables. It's also small traces are in tap water. It comes in several kinds of supplements, but the most common is usually a magnesium salt, like magnesium sulfate. As I said, with deficiency, it's hard to detect, but it's classified as a deficiency if it's below 0.75 millimoles per liter. The causes can be because of inadequate dietary intake, alcoholism, malabsorption. Also, medications can interfere with the absorption of magnesium, and of course metabolic syndrome also interferes. Symptoms can range from mild to quite severe. A long-term deficiency can lead to hypocalcemia, diabetes, even heart disease. And in the elderly population, it's an even greater concern because they have a lot of these problems. Toxicity can result, and it's not very common, but it can happen with excessive supplementation or ultravenous administration of the mineral. And symptoms can range from diarrhea all the way up to death. Magnesium has several functions in the body. It helps mineralize bone, it helps hormone production, blood clotting, heart rate or blood pressure, muscle and nerve intervention, and keeping a normal heart rhythm. And more specifically with the heart functions, magnesium is able to help in myocardial metabolism, keep homeostasis, helps with the regulation of potassium and calcium, as we know, which is vital to the having the heartbeat stay in rhythm as they should. Also has important vasodilating and anti-inflammatory properties as well. If we take a closer look at atrial fibrillation, as we said, it's the most common of all arrhythmia, and that's just when the heart begins to flutter. Beats can get up to 400 beats per minute. It causes the blood to not be able to get to the rest of the body, can ultimately result in heart failure and death. And magnesium helps, as we learned, it helps to attenuate these effects. So since with all this knowledge about how magnesium influences the heart, several studies have been done over the years, and these are just a few of the most recent that are looking at the impact of magnesium treatment either before or after heart surgery. And as you can see here, several large meta-analyses were done in 2012. Some show that there was a positive reduction in the the rate of cardiac arrhythmia after treatment. And we can see later on in other studies, depending on the type of therapy that was given and the size of the study, or the size of the population, also the amount of dosing and things like that, these results vary. They're across the board. We have some where magnesium was effective, and several where magnesium made no difference in decreasing the amount of arrhythmia after heart surgery. So as we can see, there's very mixed findings. The size, duration, methodology of these studies vary quite a bit. But perhaps the greatest underlying problem with a lot of these studies is that the blood serum levels, is very difficult to measure magnesium in the first place because it lacks sensitivity. So that may be why these are varying so much in all these different studies. So the results, or the hypothesis and objectives of this study, are hoping to find out what the efficacy of high magnesium diet would be in treating cardiac arrhythmia, and specifically want to determine whether or not a high magnesium diet should be incorporated into the treatment call for cardiac patients in the future, and also determine the degree of protection that can be attributed to magnesium in the diet specifically. So many of the other studies looked at oral supplementation and intravenous administration, but very few have analyzed the contributions that come from magnesium diet. First, we hope to recruit at least 200 cardiac patients from the University of Maryland Medical Center, and these are patients that have been admitted within the last year with cardiac arrhythmia. And at baseline, they'll be evaluated with both cardiac evaluations and just full physicals. They'll be looking at any kind of magnesium deficiency symptoms. They'll run blood serum tests, all the standard tests, but in addition to that, we're going to include an EXA test. And that's important because that's been proven to be more effective, more accurate in finding deficiency in magnesium. So once we do all that screening, we'll be able to randomize those that qualify in the study into two groups, either control or intervention. And both groups will be given heart rate monitors, wrist monitors that they can wear throughout the study, and they'll be instructed how to use those by the medical staff there at the University of Maryland. And both groups will be followed. But the intervention group will be given a dietary intervention. We'll discuss that more in the next slide. But basically, both groups will continue on. It'll be followed up with every 6 months, and at the end of 3 years, we'll be able to analyze the results of what happened in these studies. At baseline, as I said, with the dietary intervention group, they'll be given a 3-day food intake questionnaire that they'll complete with the help of a registered dietitian. And we'll recommend, and across the study, we'll have all participants use the USDA Super Tracker MyPlate, Choose MyPlate website to be able to enter in their 3-day dietary recalls. And after that, they'll receive counseling with the registered dietitian and get a list of all the magnesium-rich food sources and recipes, meal plans, things to get them all prepared for to be able to try to add in more magnesium into their diets. And then monthly phone check-ins will be made with the dietitians as the study progresses. And then at each 6-month interval, these tests, the EXA test, the 3-day intake, and the heart rate monitors will all be evaluated. And at any point in the study where a cardiac event does happen, that will be recorded and won't necessarily have the subject removed from the study, but they will need to, they'll just be keeping track of those events. And as I said, as we recruit the patients, they will be from the University of Maryland Heart and Vascular Center, and they will have had a cardiac event in the last year. They'll go through medical screening, family history, lifestyle history screenings, or questionnaires. They'll have the physical examination, as we talked about. The inclusion of patients will be those between the ages of 60 and 80, and that they have magnesium levels below 0.85. And that's a little higher than what is classified as a deficiency, but most researchers feel that that is more representative of a deficiency, and levels don't need to drop quite as low as 0.75 to start to have symptoms. Exclusion patients will be those that are on anti-arrhythmic medications, any blood thinners, pacemaker, any problems with their kidneys, liver, or have hypercalcemia, or any problems with smoking and alcohol abuse. And also, patients will be withdrawn from the study if a cardiac arrest occurs, heart failure, any stroke, any severe events, life-threatening problems. Those will be removed from the study, and also those that are unable or unwilling to wear the heart monitor as directed. So as I said, the research setting will be there at the University of Maryland Medical Center. That's where all the screening, testing, consultation, follow-up appointments will all take place. All the lab work will be done there. And this way the researchers will be working closely with the medical staff there at the hospital. And with so many people working together, there are measures in place to keep privacy, confidentiality. Patients will always be in private patient rooms for their consultations, for their tests, for anything they have done at the center. And special precautions will be taken to make sure that although we will have patient identifiers throughout the study, those will be coded, and all information will be locked on a password-protected site through the UNE network. And again, there are some risks, potential risks to this for patients. They might find some of the questions a little sensitive. The privacy breach is always a possibility, even with all precautions in place. They might find the burden with the time and travel. This will, patients will all be compensated for their time and travel and any expenses they incur during the study. And also, as a side note to that, with their insurance, we will utilize that if patients have it. If not, those funds will be taken from the those that we gather from research grants and those that have contributed to the study. And we also find the monitor inconvenient to wear. But the benefits far outweigh any risks. They'll have close cardiac monitoring, nutritional counseling, so this can mean great things for their health and also improve our knowledge about what we know about magnesium deficiency currently. And the data will be analyzed, both nominal data and continuous interval data, through measures of central tendency and variability to kind of give us an idea, make sure our sample size is appropriate and all is taken into consideration for that. The continuous interval data will be measured with an ANOVA test, and blood serum levels, milligrams of magnesium per day will be looked at, and time and number of cardiac events will be compared using that. And also the Cox proportional hazards modeling will be used to test to see what the relationship is between magnesium intake and the time to a cardiac event. We expect patients to have fewer cardiac events that have been given the dietary intervention, and magnesium hopefully will be beneficial in decreasing that risk. There are many contributions to this field. Greater emphasis could be then placed on magnesium-rich diet. Physicians and nutritionists would have greater need to work closely with patients and others to be able to ensure that more frequent and regular accurate assessments of magnesium take place. And it's exciting because if this instrument is effective in measuring the amount of magnesium in the diet, and we're able to check it more regularly and more easily, we can be able to prevent a lot of the diseases and nutrient deficiencies that occur.